Let's go through the warm-up for Endocrine 2. First question, what are the two nervous tissue bundles that run through the GI tract and where are they located? So there's Meissner's plexus, which is located in the submucosa, so sometimes it's called the submucosal plexus, and there's Auerbach's plexus, which is located between the two layers of the muscularis propria. This is also called the myenteric plexus. Next question, what diseases specifically damage the anterior horn? So you have polio, West Nile virus, ALS or Lou Gehrig's disease, and Vergnig-Hoffman disease. All right, that's it for the warm-up. Let's go ahead and get started with the lecture.
So I'm hoping that, like me, hormones are your very favorite topic because we have a ton of hormones to cover. Just imagine all those hormones working right now. It's a miracle that we all aren't just freaking out. Those hormones are shaping our metabolism, allowing us to grow, maybe taller, maybe wider, helping us to reproduce, allowing us to lactate and virilize. Well, maybe not lactating and virilizing at the same time. So anyway, today we're concentrating on the pituitary gland. This can be an intimidating topic for some students because it seems like there are so many hormones associated with the pituitary gland. In fact, there are many hormones associated with the pituitary, but in fact, the pituitary only makes 8 endocrine important hormones, 6 from the anterior part and 2 from the posterior part. And of course, many of these hormone systems have upstream regulating hormones from the hypothalamus and downstream hormones from their various target glands. And this can get complicated really fast, but don't worry, this lecture will make it as simple as possible. Now, I know you're all itching to get on to these very exciting hormones, but let's begin where we begin with development. So how does the pituitary develop? It's important here to remember that while the anterior and posterior lobes of the pituitary are both technically pituitary, they're really kind of like two separate organs smashed together into one little cella. So the anterior lobe forms from Rathke's pouch. Rathke's pouch is an ectodermal diverticulum of the primitive mouth that invaginates upward. The posterior lobe forms from an invagination of the hypothalamus. This is originally derived from neuroectoderm. And in fact, the action of the posterior pituitary is similar in ways to the mechanism of nerve endings. Okay, now let's move on to the hormones. So in the last lecture, you had a crash overview of many of the hormones of the pituitary, but now let's spend a bit more time on these and go over some pathology of the pituitary gland as well. So since the posterior pituitary only has 2 hormones, let's start there. So first we have the hormones of the posterior pituitary. These 2 hormones are produced in the hypothalamus, but they're stored in the posterior pituitary. And it's kind of an interesting arrangement. So they're unusual among the hormones in that there aren't any upstream or downstream hormones for these 2. They're created, stored, and then released directly to their targets. They still travel through the blood though, so they get to be called hormones. So the first posterior pituitary hormone is ADH, or antidiuretic hormone, also known as vasopressin. Say this with me, antidiuretic. So it's easy to get confused with this system because the hormone name creates a lot of double negatives. And I tried to think of another name for it to avoid the double negatives, and I couldn't come up with much. Pro-water conservation, maybe? So anyway, antidiuretic hormone decreases urine output. It's antidiuresing. It does this by increasing the water permeability in the distal tubules and the collecting duct of the kidney. So in other words, water is moving from the urine back into the kidney, and the end result is less water being excreted into the urine. So ADH controls the salt and water balance in the body by signaling to the kidneys whether more or less water needs to be eliminated. So basically, more ADH is less urine by volume, but more concentrated, and conversely, less ADH is more urine volume, but dilute. So imagine the salt to be more or less the same in the urine, but the water being more or less according to the antidiuretic, or water conservation if you like, hormone level. So ADH has another job to go with its other name. It's also called vasopressin because it causes constriction of vascular smooth muscle. It constricts blood vessels, raising pressure. So this hormone will be released in response to any volume contraction and increased serum osmolarity. And this makes sense because if water volume is low, the body will want it to hold on to any water it may have by decreasing urine output and will want to maintain blood pressure by constricting blood vessels. So this effect of vasopressin is a reason why we use this hormone clinically as an infusion to help keep blood pressure up for some patients in the ICU. Other stimulators of ADH, creating less urine, are nicotine and opiates. And then inhibitors, which create more urine, are ethanol, atrial natriuretic factor, and decreased serum osmolarity, or too much water for the salt present. Okay, The second posterior pituitary hormone is oxytocin, which you can think of as a pregnancy breastfeeding hormone. So when released, oxytocin will cause uterine contraction, and obviously this is important during labor, and it's also important after delivery because it helps the uterus contract down to a normal size, and this decreases uterine bleeding. So release of oxytocin is stimulated by dilation of the cervix during labor. Its other job is to stimulate milk ejection, not to be confused with milk production, from the breast, which is stimulated by suckling of the infant, and it can be inhibited by alcohol and stress. As a reminder, posterior pituitary hormones don't have the upstream and downstream hormones like the anterior pituitary group. The hormones themselves are produced in the hypothalamus, stored in the posterior pituitary, and then have their own action on target tissues rather than stimulating or suppressing production of something else. Okay, now we need to tackle the anterior pituitary. So as I mentioned before, the anterior pituitary and posterior pituitary are related mostly by proximity and not so much in function. And unlike the posterior pituitary, anterior pituitary hormones are pretty much entirely regulatory middlemen. They all have upstream hormones from the hypothalamus and downstream hormones at their various target glands. Before we get into it, I'm going to go over a mnemonic for the anterior pituitary hormone. So the mnemonic is flat pig. FSH, LH, ACTH, TSH, and then prolactin, intermediate, which is MSH, and GH. So FSH and LH. Let's start with our gonadotropins, follicular stimulating hormone, or FSH, and luteinizing hormone, or LH. So the upstream hormone here is conveniently named GnRH, gonadotropin releasing hormone, and downstream tissues are the gonads. The names FSH and LH come from the hormone's jobs in the female gonad. So in women, FSH stimulates the follicles, acts to grow and mature follicles in the ovary. It will stimulate estrogen production from the granulosa cells, and in men, FSH will act on Sertoli cells to mature sperm. So remember, FSH stimulates follicles, granulosa cells, and sperm. LH in women is important in stimulating ovulation and in forming the corpus luteum. It acts on the theca lutein cells to help produce progesterone, and in men it acts on Leydig cells to produce testosterone. So LH is theca lutein cells, corpus luteum, and Leydig cells. So it's very important to understand a particular about the upstream action of GnRH, gonadotropin releasing hormone, on both LH and FSH. So in order to stimulate release of LH and FSH, GnRH release must be pulsatile. So if there's a constant presence of GnRH, then the secretion of LH and FSH is actually inhibited. And this becomes clinically important if you want to suppress production of testosterone or estrogen for some reason, like in treatment of prostate cancer or endometriosis. Also note that inhibin can inhibit FSH, and progesterone and testosterone will inhibit LH. One piece of information that we'll use clinically if you become an endocrinologist and that you may need for your test is that LH, FSH, TSH, and HCG all have a common alpha subunit. Okay, ACTH and MSH. So next is ACTH, adrenocorticotropic hormone, with downstream organ the adrenal gland, specifically the cortex of the adrenal gland, which produces and secretes hormones like cortisol. ACTH will be stimulated by upstream hormone corticotropin releasing hormone, CRH, from the hypothalamus. Stress can also stimulate ACTH as well, and cortisol itself is a negative feedback on further secretion of ACTH. Melanocyte-stimulating hormone, MSH, is the only hormone produced by the intermediate lobe of the pituitary, although many times it's lumped in with the anterior pituitary group. I didn't count it as one of the 6 important hormones, but it stimulates the release of melanin by melanocytes in the skin. Its importance from an endocrine standpoint is all in its relationship to ACTH through POMC, which I'm about to discuss. So we have this section in your study guide on ACTH and MSH. So ACTH is synthesized as part of a large precursor called pro-opiomelanocortin, or POMC, which also contains the sequences for other hormonal peptides, including the lipotropins, melanocyte-stimulating hormones, MSH, and beta-endorphin. So why should you know that? Well, it's described here in your study guide, and we also have an image for you to take notes on. So in primary adrenal insufficiency, the production of cortisol is low. So the hypothalamus and pituitary are going into overdrive to make tons of ACTH, trying to stimulate the adrenals to make more cortisol. And what's the precursor to ACTH production? Well, it's POMC. So POMC is this long molecule. It can be chopped up into lots of smaller hormone products, one of which is ACTH and another of which is MSH. So you probably remember that MSH stimulates melanocytes to produce skin pigment. Well, ACTH and MSH come from this common precursor and share structural components. And when the ACTH concentration is excessive, as in Addison disease or Nelson syndrome, it actually stimulates the MSH receptors in the skin, which results in skin hyperpigmentation that we see in these diseases. So the next anterior pituitary hormone is TSH, or thyroid stimulating hormone. We're going to cover this more in the thyroid section, but briefly, it stimulates the production and secretion of thyroid hormone, T3 and T4, from its downstream gland, the thyroid. TSH is stimulated by its upstream hormone, thyrotropin-releasing hormone, TRH, from the hypothalamus. T3 and T4 directly inhibit TSH secretion. Next is growth hormone, somatotropin. Surprise, surprise, this hormone helps us grow. It also causes decreased glucose uptake, increased protein synthesis, increases organ size, and lean body mass. So the upstream hormones from the hypothalamus are growth hormone releasing hormone, GHRH, and growth hormone inhibiting hormone, GHIH, also called somatostatin, which is important pharmaceutically, as I'll describe later. Unlike the other pituitary hormones, growth hormone doesn't have a specific downstream gland, but it does have a downstream hormone, which is insulin-like growth factor 1, IGF-1. In the peripheral tissues, IGF-1 is what stimulates all the growth. So in addition to its hypothalamic upstream mediator, GHRH, growth hormone is also stimulated by exercise, sleep, puberty, hypoglycemia, estrogen, stress, and endogenous opioids. In addition to somatostatin, GH is inhibited by somatomedins, insulin-like growth factor, obesity, pregnancy, and hyperglycemia. So you might think of growth hormone as being opposite of insulin with respect to glucose functions. It decreases glucose uptake and is stimulated by hypoglycemia, inhibited by hyperglycemia. Okay, moving on. Prolactin stimulates milk production and secretion. So it stimulates breast development and inhibits ovulation, which will decrease the likelihood of getting pregnant while breastfeeding. It does this by inhibiting GnRH, which in turn inhibits production of LH and FSH. And prolactin is stimulated by TRH, or thyrotropin-releasing hormone. So what inhibits prolactin? Dopamine. And dopamine comes from the hypothalamus and is a constant tonic inhibitor of prolactin. Increased prolactin will increase dopamine levels, which will then act to decrease the overall prolactin level. Okay, so speaking of prolactin, let's move into some diseases of the anterior pituitary. But first, let me say a quick word about pituitary adenomas. These can be functioning or non-functioning, and many times are incidentally found on imaging. And in fact, most adenomas found incidentally in asymptomatic people are non-functioning. However, it's good to know that sometimes these tumors can cause enough destruction of the pituitary gland that a person will develop hormone deficiencies. And much of the gland will have to be destroyed before anything will be deficient, as you know from thinking about empty sella syndrome, in which there appears to be no pituitary gland on imaging, but in fact most of the time there's enough tissue up against the cella walls for normal hormone function to occur. Another incidental finding, but if deficiencies are present, these deficiencies tend to happen in an orderly way, first with loss of growth hormone, then LH and FSH, which are not life-sustaining, then TSH, then ACTH. And those last two can be interchanged in some cases. I don't know if this is high yield for your exam, but clinically, if you see someone with a pituitary mass, it's a good idea to carefully check these hormone levels because you might pick up deficiencies. And of course, you also want to look for excesses, as in adenomas that overproduce one or more of these hormones. And let's talk about one of these next. This is the most common anterior pituitary hormone excess, which is hyperprolactinemia. So let's go over this high-yield clinical scenario regarding high prolactin. It's in your study guide. Causes of hyperprolactinemia include pregnancy, nipple stimulation, stress, either physical or psychological, prolactinoma, which can be associated with bitemporal hemianopia, which is peripheral vision loss, and then dopamine antagonist medications, antipsychotics like haloperidol and risperidone, domperidone, and metoclopramide. In premenopausal women, symptoms can be hypogonadism or infertility, oligo or amenorrhea, rarely galactorrhea. In postmenopausal women, symptoms there are usually minimal since they're already hypogonadal. In men, symptoms can be hypogonadism also, low testosterone, which would be decreased libido, impotence, infertility with low sperm counts, gynecomastia, and then again rarely galactorrhea. So prolactinoma is the pituitary disorder in that list, and the symptoms of prolactinoma will follow amenorrhea for women, galactorrhea, also usually only in women, low libido, and infertility. And prolactinomas can, because of the location, impinge on the optic chiasm, which leads to the bitemporal hemianopia I mentioned before. So you'll notice the red mark is where there's impingement, and the yellow is the area the patient can't see in their visual field. The other visual field deficits are discussed in another lecture. So you can treat this medically with bromocriptine or cabergoline, which are dopamine agonists. Remember that dopamine inhibits prolactin. Sometimes surgical resection is needed if visual symptoms are severe, but the dopamine agonists work quickly to reduce the prolactin level, but take several months to affect the size of the adenoma, so you really don't want to leave a nerve compressed that long if you have a large tumor. Next, another anterior pituitary hormone excess. So what happens when a person has too much growth hormone? This is called becoming a pro athlete. Oh no, it's a disease, and it's called acromegaly. So what are the findings of acromegaly? A large tongue with deep furrows. Additionally, with a large tongue, commonly if you have the patient stick out their tongue, it's so large that you're going to see indentations along the edges of the tongue because it's pressing against the teeth. Sometimes the teeth will have increased spacing also. Then patients will have deep voices, large hands and feet. This may be the initial thing that you notice in a patient. If you walk into a patient's room and shake their hand, and if their hand just engulfs yours, that could be a clue that the patient has acromegaly. Then they may have coarse facial features like an enlarged nose and enlarged ears, impaired glucose tolerance, because growth hormone will cause insulin resistance and impaired glucose tolerance, which can progress to diabetes. As I mentioned before, growth hormone and insulin kind of have opposite effects, at least with respect to glucose. Then increased growth hormone in children doesn't cause acromegaly, it causes gigantism, where people have excess bone growth of their linear bones, so these children are really tall and big. Okay, so how do you diagnose acromegaly or gigantism? Do you check a growth hormone level? No, you actually check the downstream hormone IGF-1, and this is one of the few cases when the furthest downstream hormone is the most stable. So growth hormone is secreted in a pulsatile manner, so depending on when you check it, you'll get different levels. It's highest at night. When your parents told you you needed your sleep to grow big and strong, they were sort of right. IGF-1 is pretty stable throughout the day though, so it's much more reliable to check. And then a confirmatory test for someone with high IGF-1 is an oral glucose tolerance test. And this is the same test we do for diabetes screening, except instead of checking glucose like you would for diabetes, you check a growth hormone level at 2 hours. Usually glucose suppresses growth hormone, but in acromegaly this doesn't work because tumors in general don't respond to the usual feedback. The treatment is to remove the growth hormone producing pituitary adenoma, followed by octreotide administration, which brings us into the next section. Look at the study guide again, and we're going to talk a bit about somatostatin. Generally speaking, somatostatin is a hormone that inhibits the release of other hormones. So somatostatin is produced in several places in the body: D cells in the GI mucosa, pancreatic islet cells, and also in the nervous system. So it follows that the hormone has several areas of action as well, in the GI tract, on hormone production, and on the nervous system. So in the GI tract, it reduces splanchnic blood flow, reduces GI motility and gallbladder contraction, and inhibits secretion of most GI hormones. Then it decreases exocrine secretion in the pancreas, which also affects digestion. Then in the central and peripheral nervous systems and endocrine organs, somatostatin decreases hormone secretion. So this general hormone suppression obviously has potential to be clinically useful with fighting all kinds of diseases of hormone excess. Several somatostatin analogs have been developed: octreotide, somatostatin LAR, and lanreotide P, for example. And these are used to treat a variety of things, including pituitary excesses other than prolactin, if pituitary resection is not successful, so this is like acromegaly, TSH-secreting tumors, and ACTH-secreting tumors. GI endocrine excess, so examples would be Zollinger-Ellison syndrome, carcinoid syndrome, VIP-oma, glucagonoma, and insulinoma. And then you can also use it for certain diarrheal diseases. Somatostatin can also be used when you need to reduce splanchnic circulation, like in cases of portal hypertension, bleeding varices, or bleeding peptic ulcers. Okay, just to round out the section on growth hormone, patients also can have growth hormone deficiency, which is most clinically relevant in children. And this manifests with short stature and, once diagnosed, can be treated with growth hormone replacement. And additionally, there are a number of inherited disorders of growth hormone insensitivity, like Laron syndrome, although these are not problems of pituitary GH production, but rather lack of function. Okay, let's head back to the head, the pituitary, that is. One interesting and high-yield pathology of pituitary deficiency is Sheehan syndrome. Sheehan syndrome occurs sometime after delivery of a baby. So the mom has postpartum hemorrhage for some reason, and then the pituitary is underperfused. Then the pituitary gland undergoes necrosis, and the patient suffers from hypopituitarism. So what does that look like? Well, the most common initial symptom is agalactorrhea, or absence of lactation, and this is due to a deficiency of prolactin. Then women will have amenorrhea after delivery, and then they'll also have secondary hypothyroidism, which will lead to fatigue, cold intolerance, and weight gain. Rarely will this present acutely after delivery, but sometimes patients with Sheehan syndrome will have acute hyponatremia. All right, that wraps up the lecture portion, so let's go to the end of session quiz. First question. A patient's MRI reveals replacement of the tissue in the sella turcica with CSF. What is the most likely clinical presentation? Well, this is called an empty sella, and I just mentioned this briefly in the lecture, so we'll give a couple of details here. What normally sits in the sella turcica is the pituitary. So what happens when the pituitary is not there? Well, usually nothing. Usually there's enough residual pituitary tissue that's outlining the sella turcica that pituitary function will be normal. So this commonly is just an incidental finding and there are no symptoms. However, sometimes there can be deficiency of one or more of the pituitary hormones, and clinical symptoms would follow the type of deficiency. Which hormones share a common alpha subunit? These are TSH, LH, FSH, and HCG. Next, what is the most common presentation of hyperprolactinemia in a female patient? If she's premenopausal, she'll present with hypogonadism, infertility, and either oligomenorrhea or amenorrhea. If the patient is postmenopausal, she's already hypogonadal, so she'll most likely be asymptomatic from a hormone standpoint, may have optic side effects from optic chiasm compression. Then you might see galactorrhea in either a pre or a postmenopausal woman, even rarely in men. But don't think of galactorrhea as the most common presentation of hyperprolactinemia. Think of hypogonadism. Next, what are some of the possible clinical features of acromegaly? Acromegaly is caused by excess growth hormone, so think about excess growth. Large hands and feet, coarse facial features, large nose, large ears, large tongue, increased spacing of the teeth, a deep voice, impaired glucose tolerance, or even diabetes. Now let's go over the rapid fire facts for this lecture quickly. So inability to breastfeed, amenorrhea, cold intolerance, this is Sheehan syndrome or pituitary infarction. Infertility, galactorrhea, and bitemporal hemianopia, this one is prolactinoma. And that's the end of our lecture on the pituitary. See you next time.